Good afternoon, dear colleagues, dear students. My name is Koen De Wandeler. I'm an associate professor at the KU Leuven Faculty of Architecture. And this afternoon, I will share with you how to conduct a systemic analysis of a primary healthcare center and its settings. Now, we already had the lecture on systems thinking, and in a quick rehearsal, we can look at the following. Systems thinking is basically an approach, a way to think about, to analyze very complex problems. Healthcare systems are extremely complex, and we usually only know the part of the patient. Very important to remember is that systems always have three parts. First, they have elements, the elements that are the different forces that comprise the system. They have interconnections between those elements, and these interconnections are stories and have their own importance. And thirdly, systems have a purpose. Healthcare systems have the purpose of keeping us healthy. Now, systems thinking is a way of thinking that helps people see how these different parts, these elements, interconnections, and purposes interact to form a whole, and how that whole fits or interacts with a wider context. So it will always be very important for a systems thinker to zoom in and zoom out, constantly zooming in and zooming out, and thereby discovering patterns, a certain way that elements relate to each other. Not only seeing the patterns that the elements have, but by looking at the spaces in between, see how these patterns may change over time. Now, if we look at this in a systemic analysis for a PHC facility, we will look at the way that elements, that components of a system interrelate to one another. So for every system, it's important to set the boundaries. Every system has certain hierarchies. One element or one relationship may dominate the others, and this may change over time. And see what are the interconnectivity between those different elements. Now, we can look at the system from different perspectives. We can look at it from a spatial perspective, from a temporal perspective, or from a conceptual perspective. Now, if we combine those elements, then we will try in our exercise to determine or circumscribe the spatial boundaries within which our primary healthcare center is operating. And we'll do a contextual analysis at the city level, the district level, the neighborhood level, and finally at the primary healthcare center itself. We look at the hierarchies. What has the predominance? What are the priorities? What is the chain of command in normal circumstances, routine circumstances? And how does that change in emergency situations? And then we'll look at the interconnectivity between all the users of the primary healthcare center. We look at the way that doctors relate to nurses, nurses to patients, patients to technicians, technicians to doctors, etc. So that is our task right now. And to do that task, we already shared with you a template which consists of the different levels, as I described. We'll start at the city scale analysis, where we situate the primary healthcare center in relation to the city center, historical, cultural, administrative, to major infrastructure, very important in cases of emergencies. How can outside succors reach our area? Major hospitals and emergency centers. Where do patients get referred to when the primary healthcare center cannot take care of them? Also look at geographical elements that may obstruct smooth traffic, like mountains or valleys where there are bridges that may collapse, fault lines, etc. And of course, since we are looking at primary healthcare centers in flood areas, we have to look at seas, rivers, canals, ponds, floodplains, etc. And that gives us a map, something like this, where we situate the primary healthcare center over here, vis-a-vis all those elements, and we may even clarify that through a further map at the district level, where we look at the district level either from an administrative district or a health district, because most ministries of health in your countries will have defined health districts. So either way, it should be possible to obtain secondary data on demographics, on other hospitals, larger hospitals or clinics, pharmacies, general practitioners who are operating in that area and who may come to help in the primary healthcare center in case of emergency. Medical education facilities where nurses or physiotherapists are being trained, schools and educational centers in general, because they may offer shelter in cases of emergencies, and of course the mass evacuation centers in case of emergencies. These are all part of the system, even though they may not constantly be on standby. This is the kind of data that you might find in statistics on the district, either the administrative district or the health district. And this is then what you can find from Google Map, where it becomes possible to clearly distinguish infrastructure, green area, the density of the district, the other elements, that the water elements, for example, the water bodies, all that may be important to know. Clearly, you can show this in a map, not a Google map, but a separate map. And with the dots, you can even indicate the trees, the high trees, the lower trees, because these trees along the roads, if they ever fall down due to an emergency, a tsunami, a storm, they may obstruct the road towards the health facility. So it's important to know where they are. Then we come back to the neighborhood scale, which is basically 400 by 400 meters square, around the primary healthcare center. And there, that may require a first attempt in Google Maps, but definitely will require to visit on site. And in order to determine where built and open spaces are, where community halls or civil associations have their meeting points, religious centers have their meeting points, where there are roads, bicycle tracks, the vegetation, as I said earlier, the trees that might fall across roads and obstruct traffic, and definitely also the water bodies and the marshlands, not only because they may increase or contribute to flooding, but also because they are sources of vector-borne diseases. And this gives us something like this in Google Maps and like this in a more detailed view. Then we come to the primary healthcare center itself. And of course, in a first instance, this will require that you contact them, that you may have to ask permission to visit them. And that's a good opportunity to ask them about the opening hours. When was the facility built? When was it remodeled? Why the difference? Because when it was built, it may have been built according to the building code, but the remodeling may have been done in a hurry or not following the regulations. So anyway, the years of operations are of importance. Permanent and part-time staff, important. What are the services offered? Are these services offered every day of the week, or just 1 or 2 days a week, or once every fortnight? Not likely that there will be overnight rooms, but nevertheless, it is important to know exactly, like shown in a fire escape plan, what are the rooms, what is used for administration, what is used for storage, what is a consultation room, maybe there is a dentist room, maybe there is a childcare center. What are those rooms and what are their dimensions? And finally, also, what is the medical equipment available in storage and operational for everyday use? And then, of course, we will go into more detail through the checklists. Now, to illustrate the primary healthcare center level, I took an example which one of our students looked into during the WHO technique elective of last semester at the clinic Leuven. So he gave an overview of the primary healthcare center, a view of what it looked like, but most importantly, he gave a short description which gives the information that I mentioned earlier, most of it. And then, very important, he gave this round floor plan indicating what rooms were for staff, what rooms were for patients, and what rooms were common or specialized consultation. Very important also, he indicated a flow chart of what kind of people, whether patients, staffs, or visitors, could visit what places within this primary healthcare center. That concludes our context analysis. Now, second part, we go even deeper and we try to engage into a systems mapping of a PHC facility. Of course, we will not go to the bottom of this exercise, but we limit ourselves to a checklist, a very thorough checklist, that will help us to establish how the system actually works. And as you remember, systems consist of flows and stocks. Now, in normal circumstances, the primary healthcare center would be plugged in to the grid, electricity, water, sewage, and that would allow the primary healthcare center to work. But there may be circumstances, disasters, emergencies, where the grid falls away and the center needs to rely on alternative sources of energy, solar energy, for example, or a generator that still allow the center to work as usual or nearly as normal as possible. That is one. But also very important, it will be to identify balancing and reinforcing feedback loops. In case of a flood, for example, we may assume that there is a reduced accessibility, and that because of the reduced accessibility, there may be a lack of medical supplies, which in turn may threaten the effective service that can be delivered at the primary healthcare center. Now, obviously, this loop reinforces the negative impact of the flood. And on the other hand, if the primary healthcare center disposes of alternative sources of energy, solar panels, a generator, wind energy, that can ensure that the cold storage is maintained, that the computer where the data of the patients is kept is still running and safeguarded. That, of course, is a balancing loop. So it will be important to identify those reinforcing loops and those balancing loops in case of emergency, so that it becomes clear what balancing loops should be enhanced and what reinforcing loops should be avoided. So to do that, we'll have a long list of check items to be checked. And these items will be subdivided at the district and neighborhood level, where we basically look at the hazards that may occur and that may affect the primary healthcare center. So there will be hazards that threaten the population in the catchment area of the PHC. And they may be hazards that require emergency and disaster management, not only within the primary healthcare center, but at higher levels, at the district level, but even so by religious associations in the neighborhood, civil associations in the neighborhood, or volunteers, a group of volunteers. And at the primary healthcare center, there, of course, we also need to look at the hazards that are within the primary healthcare center, posing problems to the primary healthcare center. The safety will need to look at the routine, the structural safety. Is the building sound? Non-structural safety is a bit more fickle because many of these things may have been added after the building was approved and may not completely correspond to the building regulations. Are these non-structural safety, is this non-structural safety guaranteed in emergencies and disaster circumstances? We'll have to look at the utilities, routine water and energy supply, supposing that the primary healthcare center is connected to the grid. If the grid falls away, is the water and energy supply still guaranteed, and how? And how safe is this? And then finally, we'll look at the provisions, the routine provisions that are in place for climate resilience, for infectious disease prevention and control. And then in emergencies, what are the provisions that are in place to guarantee the continued operation of the primary healthcare sector? So this entire exercise will be basically take the most of your time off the preparatory phase of the summer school. It will be a most rewarding exercise because you will be able to compare the performance of the primary healthcare center that you studied with the performance that other groups have been noting for the primary healthcare center that they studied. And from that comparison, we'll try to fine-tune the the checklist so that your colleagues next year may test it. The fine-tuned version can test it again on the same primary healthcare centers and see again what is missing, what could be improved, so that in the end, after 2 years, 2 summer schools, we can come up with a design brief how ideally a primary healthcare center should look like, should have the provisions in place to survive in emergencies and disaster and work optimally in routine circumstances. Thank you for your attention, and we'll meet soon at Thammasat Designs. Thank you.